Okay, as everyone filters in, welcomes to our third lecture of this series at the Arthur C. Rotenberg Suicide and Depression Studies program at St. Mike's and U of T. I'm Sakina. I'm the chair of the program here at U of T and St. Mike's. So for those of you who are just joining us for the first time, our goal here on our team is to really try to bridge this disconnect from researchers and the public and make sure that people have access to all of this incredible information, all this incredible research that is going on around the world. So, also, as always, if there is something you would like to know more about, let us know in our feedback form. And we're going to pop that into the chat. Just to highlight also that we are going to be here monthly until June, and then Mondays 12 to 1. And yeah, you can sign up for updates on who's coming next in the link. And yeah, so for questions, if you could use the question and answer feature at the bottom, I'll be monitoring that at the end. And also just a reminder that this is a webinar, so we can't hear or see you, unfortunately, as much as I would like to. So just, yeah, if you could use the QA at the bottom, that would be great. So also, as always, we are talking about suicide. So although we're doing it academically, I always think it's important to approach these conversations with emotional safety. So if at any time you're feeling like, this is kind of like a little bit, I don't really want to hear this, you're finding yourself being a little bit distressed, just make sure you're taking care of yourself. You can disconnect or go get a tea or do whatever you need to support yourself. These will be recorded and posted on our YouTube channel, so you won't miss anything. Okay. So I am so pleased to introduce Dr. Firoza Mamdani. She's an assistant researcher in psychiatry and human behavior at the School of Medicine at University of California, Irvine. So her research focuses on translational studies, bridging molecular neuroscience and clinical psychiatry by integrating clinical gene expression and postmortem brain studies to identify biomarkers of neuropsychiatric disorders, accelerated aging, and suicide risks. So in this talk, she's going to present on recent work identifying blood-based biomarkers for suicide in patients with major depressive disorder. So welcome so much, Firoza. Looking forward to your talk.
Hi, thank you. All right, I will share my slides then. Oops. There we go. Can you guys see this? Is everything okay?
You're good.
All right, great. Thank you. And do let me know if by chance you do not hear me at any point.
I'll let you know.
Okay, great. Thank you. All right, so hi, my name is Firoza, and well, before starting, I just wanted to thank Dr. Rizvi for the invitation and that nice introduction, and as well as her team and colleagues who really helped to arrange and coordinate this talk. And so with that, I'll get started. So with this talk, I hope that you will, by the end of it, hopefully gain additional understanding of translational study design and methodologies that can be used. Learn how to identify genes that are differentially expressed in those who have died by suicide, and as well learn about the potential clinical applications of biomarker research. So suicide is actually the third cause of death in men between the ages of 18 and 44 in the US. I know I've focused these statistics for the United States because, well, we're here in California, but the numbers are actually quite similar for Canada. 1.4 million suicide attempts are carried every year in the US, and about 49,500 Americans in 2022 died by suicide. And that's actually a 3% increase from 2021 data, according to the CDC. And more men actually do die by suicide, about 4 times more than women. And we're realizing that there is actually a window of opportunity to identify patients that are most at risk. And studies have shown that 1 week after patients leave psychiatric care, the suicide death rate actually tends to increase by about 300%. And about 45% of those who actually die by suicide do see a clinician in the month prior to their death. And 1/3 of people who have passed away by suicide actually see a healthcare professional within the week of dying. But unfortunately, there still is currently no accurate way of predicting who is at risk for suicide. And this is what we're trying to do, and we're trying to answer this question. Can we identify patients who are at risk for dying by suicide using molecular data from postmortem brain and blood, and also from blood collected from at-risk clinical populations? And to answer this question, we're looking at two groups to provide us with information. First of which is a postmortem sample from which we can actually obtain brain samples, blood samples, as well as we have clinical and medical information. And the other is a clinical sample of living subjects. And in our case, this is a group of people's major depressive disorder, which moving forward, I will abbreviate and refer to as MDD for the rest of the talk. So if you do hear me say that, this is what I'm referring to. And a group of control subjects from this clinical sample, and they have no psychiatric issues. And as well for this sample, we do have blood and clinical information. And between these two, what we do want to compare is molecular data. We'll be focusing on transcriptomics, so RNA expression, gene expression, so looking at genes that are on or off. But you can also do this looking at genetics or epigenetics, so regulation of gene expression, or even metabolites, so investigating metabolomics. So first, I really like to focus on the postmortem sample. And before we delve into that data, I want to start by giving you a brief overview of our brain bank at UC Irvine. So we're very fortunate to have a brain bank at UC Irvine that consists of brains that were donated by family members. So for that, we are very grateful. And our brain bank was actually founded in 1989 by Doctors William Bunny, Steve Potkin, and Edward Jones. And Dr. Bunny is actually listening, and we still work with him. We're all working together. And we do have a very strong partnership here in Orange County with the Orange County Sheriff's, as well as the Coroner's Office and regional tissue improvement organizations. And through this, we are able to get donations for our brain bank. So in addition to whole brains, in our brain bank, we also have skin samples that we can use for fibroblast isolation and culture, as well as cerebrospinal fluid, liver, and blood samples. And we have an extensive collection of 170 fully characterized brains, which includes cohorts of different psychiatric disorders, such as bipolar disorder, major depressive disorder, schizophrenia, as well as non-psychiatric control cases. And also many of the psychiatric cases that we have actually died by suicide. So the brains were donated following death by suicide. And each of these brains and biological samples is actually supported by a 156-item psychological autopsy, and along with detailed demographic data, perimortem medical data. And we also have rigorous quality control metrics, which include the peach RNA integrity, evidence for neuropathological inspection. And these metrics are very useful for us when we're performing genomic studies. So far, what have brain studies actually told us? Well, studies have shown that high cortisol levels have been associated with increased levels of stress and anxiety. And this is also observed in patients with mood disorders, such as depression or bipolar disorder, as well as suicidal subjects. And in our postmortem brain studies, so in depression and suicide, we have found alterations in gene expression of metallothioneins, which are involved in protecting against oxidative stress, in polyamines, which are involved in responding to cellular stress, as well as GABA and glutamate subunit, receptor subunit genes. And GABA and glutamate are neurotransmitters, and they're in an imbalance in GABA and glutamate can actually lead to depression and other psychiatric disorders. So these findings altogether suggest that some patients might respond differently to stress, and that this altered response makes them more predisposed to suicide. And one of the main findings from our group is that of decreased SAT1 gene expression. And SAT1 is a gene encoding for an enzyme involved in the regulation of polyamines. And this decrease in SAT1 gene expression we have observed in depression and suicide, along with findings of alterations of other polyamines. And we're fortunately, which is also an issue at times with some findings with some genomic findings, is that replication is an issue. However, we fortunately, and this finding of SAT1 has been consistently replicated by our group as well as other groups. So coming to suicide-specific biomarkers, so genome-wide association studies that deal with genetic data, as well as functional studies looking at methylation and gene expression, often compare MDD suicides to controls, or will be studying suicidal behaviors, such as ideation and attempts in clinical populations. And most of these studies have actually looked at brain or blood independently and not together. For the blood, though, especially when we're looking at postmortem samples, there can be some issues to deal with. So postmortem blood can be very difficult to collect when the PMI, which is the postmortem interval, is high. So if it has been many hours since the time of death, blood can actually be quite coagulated and also have some cell lysis. And postmortem blood is not always collected in groups that have a preservation buffer. And this preservation buffer helps to maintain the integrity of RNA. And with regular blood tubes, this is actually not the case. And as a consequence, RNA can be often too degraded to perform quantitative PCR or run microarrays or do RNA sequencing. So this brings us to the question of, can we actually combine brain and blood expression signatures to be able to develop a transcriptional blood test to assess suicide risk? And we ask this question because very often patients will deny having suicidal ideation, suicidal intentions. And having a blood test focused on suicide-specific genes could actually help physicians identify at-risk patients in an unbiased way. And then to be able to try and answer this question and circumvent the issues that we see with postmortem blood, we're using a specific gene expression platform, which is called the NanoString. And with this platform, the NanoString platform allows us to actually directly count each of the mRNA molecules using their proprietary barcode probe system. And one of the advantages with doing this is that you do not have to deal with cDNA. Because when you have some RNA degradation, it's actually a problem for cDNA production. And cDNA is what is being used when we want to measure gene expression by qPCR with microarrays, and as well also for RNA sequencing. And what we've seen is that even with some degradation in the postmortem preserved blood, we're actually able to extract enough RNA to reliably detect changes in gene expression using NanoString. And we were able to also do this by loading more RNA from our blood samples, because this helped to increase the quality. So to identify the suicide-specific biomarker in MDD, we conducted a postmortem study in postmortem brain. And specifically, we were looking at the dorsolateral prefrontal cortex, which is the frontal cortical area of the brain, as well as blood. using nanostring, and we investigated 117 genes that are relevant for suicide. And we did this in a group of controls, people with depression who died by suicide. So that's the MDDS grouping. And people with depression who did not die by suicide, so died of other causes. That's the MDDNS. And then and then psychiatrically normal controls. And so in the dorsolateral prefrontal cortex, we actually identified 21 genes that were significantly differentially expressed between MDD suicides and MDD non-suicides. And they're depicted here. Let me see if I can show you by my mouse. So depicted here in orange for the MDD suicides and in gray for the MDD non-suicides for each of these box whisker plots that we have. And we saw that the significant genes that were identified that were differentially expressed between MDDS versus MDDNS included SAT1, metallothioneins, genes that are also involved in maintenance of telomere length. And telomeres are protective caps at the end of your DNA, and they protect your DNA, as well as genes that are involved in stress response, as well as circadian rhythm, so related to your sleep cycle, and immune response. But so this is in DLPFC, but well, what about blood? What do we see? Well, in blood, we found 11 genes that were significantly differentially expressed in MDD suicides compared to the MDD non-suicides. And these were similarly involved in immune response, circadian rhythm, telomere length, stress response, and also mitochondrial dysfunction. And when we look at similarities between the DLPFC and the blood, we found that there are genes involved in immune response and circadian rhythm and telomeres that have altered gene expression in these subjects in MDDS that can be identified in blood. And if you look at the graphs, the direction between brain and blood is not always the same. However, this is not something that we're too concerned about because technically the brain and blood are two different tissues. So we're not always expecting the directionality to be the same. What was important here was to note that these genes are significantly differentially expressed in suicide for depression. And so our next step, having done this, was actually to validate our findings in an independent and larger sample of postmortem blood. So we conducted this confirmation of our blood-based suicide biomarker in postmortem blood that was collected from a sample of 31 MDD suicides, 15 MDD non-suicides, and 26 psychiatrically normal controls. Once again, because we were using non-preserved blood, we went with the NanoString platform to run our gene expression assays. And in this one, instead of 117 genes, we were looking at a few additional ones. So we looked at 127, and we used ANCOVA models for analysis. So what we did find when we were doing this was that we found 32 genes to be significantly differentially expressed in the MDDS compared to MDDNS groups. And our genes that are highlighted in red are actually concordant with our previous findings, which we have already published. So here I've put both of the gene lists side by side. So when we're looking at both of the significant gene lists between our previous study and also our independent sample, we see that the top two genes are actually similar, which are PER3 and MTPAP, as well as 7 others. And now what we can say, I feel, with a certain level of confidence is that these 9 concordant genes are strong candidates for a suicide-specific biomarker. And just to kind of summarize the molecular significance of these 9 genes, NR3C1, POT1, TERF1, and GAR1 are involved in stress response. So these are genes that can influence how the body and brain actually cope with chronic stress. And we have 2 genes, CREB1 and GPR37, which are involved in brain function and mood regulation, as well as memory and communication between brain cells. And then the last 3 genes, PER3, MTPAP, and SLC25A26, are genes involved in sleep and cellular energy. And they're genes that can help regulate sleep patterns and support energy production in cells, so specifically linked to mitochondria. And well, since these findings were actually observed in postmortem samples of MDD suicides, we want to be able to translate these findings. And to do this, to translate these findings to the clinic, we are actually trying to determine if these genes are altered in a similar way in people who have depression and who also may have higher levels of suicidal thoughts and behaviors. So this brings us to look at gene expression biomarkers in a clinically depressed sample. So this is a large clinical sample that we have that was collected across 3 sites, actually. It was a concerted effort between us at UC Irvine, our colleagues at Stanford, as well as Cornell. And for this sample, we have 107 subjects, of which are 100 controls and 107 depressed individuals. And we actually have a lot of clinical data for these subjects that come from several different questionnaires. Depression with the Hamilton, suicidality using the Columbia Suicide Scale, as well as measures of hopelessness, perceived stress, psychological pain, as well as pleasure or anhedonia, and then adverse childhood events or childhood trauma. And for the purposes of looking at suicide, we are taking information from 2 questionnaires. So specifically question 3 in the Hamilton Depression Rating Scale, which is the question for suicide. And also we are looking at the severity of the most recent suicidal ideation from the Columbia Suicide Severity Rating Scale. And what we did with these samples, these were blood samples again, we performed qPCR to assess the expression of the 9 genes in our blood-based suicide biomarker. As well, we added some additional circadian genes, which were PER1, PER2, CRY1, and BMAL1. And these circadian genes were included in our nesting panel, but did not reach significance, but are still interesting because of the relationship of sleep disturbances and suicide and depression. And so before I delve into the results from the qPCRs, I wanted to give you a closer look at the distribution of the Hamilton question 3, as well as the CSSRS scores in our sample. So here you can see the distribution for question 3 between our controls and our depressed sample. So the majority of the controls, like 99 out of 100, did not respond. Their response scored a 0 with an absence of any suicidality. And with our MDDs, we see a distribution between ranging from 0, so absent, to mild, moderate, marked levels of suicidality. And there was one subject who actually did have severe levels of suicidality. And okay, let's see. So then for the CSSR, what we do see is that all of the controls, so all 100, had no levels of suicidal ideation, as well as actually 32 of our depressed subjects had no suicidal ideation. With the remaining with the remaining subjects having a distribution of different types, different levels of ideation, which ranged from a score of 1, where you wish to be dead, to actual active suicidal ideation with a specific plan and intent in about 10 of the subjects. So when looking at the qPCR results, we measured gene expression changes in the clinical blood samples in these MDDs and controls. And several of the gene expression changes were significantly different between MDD cases and controls. So if you look at the second column, so these are related to diagnosis. And so these are related to diagnosis, so they're differentially expressed between the depressed individuals and the controls. And importantly, you can see that GAR1, FKBP5, PER2, and CRY1 actually showed a strong correlation with the severity of recent suicidal ideation. And this supports the potential value of these genes as a biomarker for acute suicidal risk. As well, these results provide us with an initial translational evidence for the applicability of our biomarker in a real-world clinical setting, and it highlights the biological relevance of circadian and stress-related gene pathways. One thing to note is that this is our first analysis, and we do need to look into this a little bit further. And I realized that I've actually spoken very quickly. So I wanted to just summarize our findings for you. So we have identified brain and blood transcriptomic biomarkers, which can be translated into a clinical population of MDDs, and to study these molecular biomarkers associated with depression and with severe suicidal ideation. As well, we can see that gene expression in blood can be used to develop a short-term risk signature for suicide. And in the future, we do need to perform more comprehensive studies, which can combine gene expression along with epigenetics, such as methylation and telomere length, in highly suicidal clinical samples to refine the suicide biomarker that we have found. And very fortunately, this is actually the basis of our recently awarded Blue Sky grant from the American Foundation for Suicide Prevention. And with this grant, we will be studying using a within subject design, where subjects in this case are actually going to be recruited while they are highly suicidal. So they will be recruited from our hospital emergency room, as well as our psychiatric inpatient unit, and then followed up when not suicidal. And this sample is different in comparison to the clinical sample that I described earlier, in that here the patients will be recruited when they are highly suicidal. For our other sample, we recruited them more so based on the severity of depression at study entry. So in this new study, the identified suicide-specific molecular gene expression, as well as epigenetic biomarkers, will be combined with all of the clinical data that we collect to, in the end, enhance our understanding of immediate and enduring molecular changes that are associated with suicide, and with the goal of helping clinicians assess suicide risk in their patients. And with that, I will end, and I want to give my thanks to our team and our colleagues at UCI, as well as our Pritzker Consortium that we are part of, the Genomics Hub at UCI that helped us do some of the higher throughput analyses, as well as our funding sources.
Thank you so much, Firoza. That was a really interesting talk. I've learned a lot from that. And for everyone, again, like I know we have some questions coming in, but again, if you could use the Q&A function, that would be great. So I think it's really interesting how you have your genes that are markers of maybe of suicide death, there's things that are associated with ideation.
Hmm.
Could you maybe like summarize that? There was a question around whether markers show differently when the same person is actively suicidal compared to when they're not.
Actually, a very good question. And that is definitely something that we can look into. And we also do have that same question. So I really appreciate that one because we also don't know. Like suicide is a state. We're believing that you're in a suicidal state, but you may get out of it, and you may feel better, and your suicidal ideation may reduce. And so, fortunately, with the way that we've designed our clinical studies, we actually follow the subjects. We have followed them for a year. And so we have gene expression data at follow-up, so at 1 year follow-up, as well as suicidality measures. So that data, we can compare then the data that I showed you to how these subjects are feeling 1 year later and actually look at the change in expression to answer that question and to see if levels do stay the same or if they have changed.
Yeah, that's really exciting work. I actually see like, when you're looking at the genes with respect to like immune function, circadian rhythms, telomeres that
Mm-hmm.
protect your genes, like so I'm hearing that with that genetic, there's some level of a genetic predisposition to how we manage stress. I guess the other side of that is like
Yes.
that's pretty exciting because these are also things we can do something about. So like I'm wondering if you can
Yes.
kind of like speak to that.
That's actually a very good point. And telomeres, for example, we do know depressant use can actually increase the length of telomeres, but also for all of us normally, exercise actually does help. And we do know exercise can help reduce amounts of stress and actually help you sleep a bit better, which could be very helpful. And so these are uh, definite things that we can do.
Yeah, I do find that really hopeful that we're kind of as trying to
Hmm.
identify
Very
genetic things.
much.
It's not like a this is it and that's all you can do. That there's really is now things that we can actually do to prevent things or
Exactly.
to adjust how we react to certain experiences as well. Um,
Exactly. Because the like our genes don't determine outcome.
yes,
It's
exactly.
kind of informing that we
Yeah.
have a predisposition, but the outcome is also dependent on life stress and also environmental factors. And those are things that we can manage, like you said.
Yeah, exactly. So, I mean, I think that's such an important
Hmm.
point that you don't inherit behaviors. So, like, I know that when
No.
they talk about, suicide risk running in families, like, you don't inherit a behavior. So,
Mm-mm.
when people talk about, risk when it comes to how suicide risk might show up in families, how do you interpret that information, given the fact that you don't inherit a behavior?
That's a very good question. So we do know. You're probably familiar, and maybe many of the people who are participating in the talk in the talk are actually familiar with there have been genetic studies, so we do know that there is some predisposition that is passed on in families. For example, with the clinical sample that we have noticed not necessarily suicidality, but we've noticed that the psychiatric disorders will run in families. And with environment, we know that also plays a different role. I'm not sure I can give you a specific answer because I think this is something
Hmm.
we're all trying to still, this relationship is something we're all still trying to
Yeah.
figure out and try and explain. Because we know, I think that would be the answer. We're still trying to figure out exactly what it is. And I don't know, I do think to an extent coping is part of it. Like how you end up coping with things is also related to how your body is responding to stress.
Yeah.
So that some coping mechanisms may be useful, but it's definitely an area that we still need to we still need to delve a bit deeper into to determine what is actually going on because we know environment can affect people in different ways. and what
Yeah.
is actually happening at a genomic level to aid in that. We're not 100% sure yet. It's something we're still looking into as a whole in terms of
Yeah.
this research.
Yeah, I find that that interface between like biological, psychological, and social is so
Mm-hmm.
interesting to
Yes.
me because we talk about coping strategies. I'm a therapist. We're like, here, let's develop your coping
Mm-hmm.
strategies, but it does also have to be positioned in terms of how your nervous system does respond to things, and that's
Yes.
very biological. And that
Mm-hmm.
we've all had situations where it's like my nervous
For
system's
sure.
just reacting and I'm having a really hard time. I can't just, and I'll often tell my clients, like, you can't talk yourself through that. You need to have different
Yep.
strategies for that. So like I feel like this interface is really interesting because of that, because
Mm-hmm.
it might indicate to someone that, like, okay, well, maybe you have a genetic predisposition to manage
Predisposition.
stress a certain way. Uh, and now that we know that you might have a certain level of nervous system
Mm-hmm.
reactivity to it, how can we work and
Yes.
adjust our coping strategies to help you manage that better?
Mm-hmm.
Right.
Very much
Yeah.
so. And
Yeah.
I feel sometimes when we do research, we're like in a silo. We don't necessarily have all of the data to be able to integrate these findings. And
Hmm.
that's one of the nice things with the translational work that we do. We're able, a lot of data. There's a lot of clinical data and a lot of in both our postmortem and our clinical samples. But it goes back to what you were saying, is to be able to try and integrate all of these levels of information together to end up helping the patient better.
Yeah.
And with what we have, like I know that our findings are mostly at the genomic level, but what we are trying to do is trying to incorporate more of the clinical phenotypes and the clinical aspects to see where there are other instances that we can help the patient, because we do see, I didn't show the data, but we in our subjects we see correlations with suicidality along with levels of hopelessness, levels of psychological pain, also
Mm.
levels of perceived stress, and different types of childhood trauma. So there are explanations there, but I think we still need to delve a bit deeper into that. But I think it's a good start, but we do have a
Yeah.
ways to go.
Yeah, and I think that it kind of highlights certain things that we need to kind of zone in on even further, right? There's
Mm-hmm.
been so much research in sleep and how that can be a risk
Yes.
factor for suicide. It's like very well
Mm-hmm.
established that if you're not sleeping well and you're experiencing suicidality, that's not a good situation, but let's work on your sleep.
No.
And
Mm-hmm.
so I feel like these things are also kind of helping us zone in a little bit more biological information, so like helping us. This is what we really need to focus on.
Exactly.
Yeah, yeah,
Exactly.
yeah, for sure. So there's some questions here. How do you
Sure.
envision these findings being applied clinically? What would people be tested for in those genes to predict who might be more likely to die by suicide?
So our aim would be to do a eventually to just have a blood test that will measure gene expression for these genes. So to similarly to what we've done here, but just for the minimal amount of genes that would be included in a biomarker. And our aim would be that with this data, what we have seen is also that because we can use non-preserved blood, this is something easy that can be easily implemented at a clinic or at a hospital, because we don't
Yeah,
need any special tubes. It's really just going to the phlebotomist and getting your samples. And then it would be either to test at a university lab within the university itself, or long term, the actionable goal would be to have this as a blood test that would be commercially available. But we're that is in the future. We're not at that stage yet. But
yeah.
we would want to be something simple to implement and be something also very that can rapidly give clinicians some information.
Yeah, yeah. And I think that that's also important to recognize that this is another piece of the puzzle.
Yes.
That when we think about suicide risk, it's very multifaceted and there's different pathways to it. that pass, like, the biological, social, systemic factors, psychological. So this biological
Mhm.
piece, when it comes to suicide risk for those that are listening, hasn't been as studied as other things.
Yeah.
And so I think that it's really exciting, the work that Firoza is doing here, because there's not a lot of people globally doing this kind of work, and we need more people doing that. So I think it really does offer that other piece of a puzzle that you can integrate with
Mhm.
other things that might be happening, because environment and other things like
Yeah,
systemic factors make a big
very
difference
much
as well.
so.
Yeah. So another question, comment from someone in the audience was they had lost their youngest child just over a year ago to suicide, which I'm very, very sorry for your
So
loss, and thank you
sorry.
so much for coming to this talk. And there was depression as well as a severe brain injury. And they had complained a lot of like nightmares, loss of memory, loss of smell, and it would have
Mhm.
helped the family to understand the interactions of the genetic factors and circumstance. So thanking you for your work, and
Thank you.
thinking that it would also will help to reduce stigma also, which their son had experienced. So what do you suggest would be the most helpful to share with other families at this point about the work that you're doing?
Okay. Oh, well, thank you so much. And also, I'm really sorry for your loss. And really, thank you. Thank you for your support in the work that we're doing and anything that all of the researchers and suicide research are doing. Really appreciate that. I think at this point, if to talk to other families, maybe is to say that people are we are looking into this and we're trying to find reasons behind what has happened. And also, I'm happy you mentioned stigma, and this is one thing like a blood test can help with because it's not uh, it's not something that necessitates having to talk too much. It's more like if you are feeling down, and if your clinician is able to say, okay, you know what, we're just gonna take a blood test just to give us that other piece of the puzzle, and that would help because it's somewhere you do not have to feel any apprehension or any um, shame or guilt for having suicidal thoughts. And so I would say maybe for other families just to hang in there. We are looking into things and we're trying to advance this field to be able to help other families like yours.
Yeah, absolutely. And if everyone was here for Dr. Bergman's talk last month, again, highlighting the idea that um, really trying to position that there's nothing wrong with someone having
No,
suicidal thoughts.
no.
It's a cue. It's a cue that it's something in and of itself. It's that there's something going on in my that I'm overwhelmed by, that I'm feeling like I need to escape. Let's find out what that thing is. So you really start to see your suicidal thoughts almost as a signal. It's a symptom of something else,
Mhm.
right? And so we're trying to keep that in mind, and sharing that with families as well, that there's nothing wrong with this. It means that someone is overwhelmed. This is how they're
Mhm. Yeah.
experiencing it. So you have looked at these biomarkers in the context of major depressive disorder. What do you think you might find, like with
Yes.
other illnesses like bipolar disorder or schizophrenia? Like, do you think that this would track?
Hmm. That's a really good question. I think with the closely relatedness of bipolar and depression, I
Mm.
would assume that many of the genes would track. And what we also see is that stress response, as well as immune regulation, even telomere length or mitochondrial dysfunction, are systems that are altered in all psychiatric disorders. I think at this stage it's more just levels. However, it's actually a good direction to also take our suicide biomarker would be to check in these other populations because they also experience suicidality and death by suicide. So, and fortunately enough, we do have the samples to be able to do this. This would be a logical next step, would be to open this up also to other disorders. So I would believe that we would see at least a similar pattern in terms of more global pathways, maybe not specific genes, but that we won't know until we actually do the
Okay.
investigation. But
Yeah. Yeah. I guess because we were talking about coping strategies, so I was like, well, I'd love to find out more about
yeah.
coping mechanisms. Where might I research that? And this individual has had suicides in their family as well.
Hmm.
I guess it's curious because we were talking about different coping mechanisms. I'm
Yeah.
wondering if you have thoughts on that. I definitely, as a therapist, have lots of thoughts on that, but I'll let you speak to that first, Firoza.
I was actually gonna I was gonna defer to you a bit more. I am
Okay.
a geneticist by
I
training,
can
so
totally.
I
Yeah. Yeah.
I deal with patients now, so I am part with other clinicians in our group to recruit our depressed individuals. So for me, this is a new avenue, and um, I don't think I could I could answer
That's fine.
the mechanism
Yeah.
question very well. So I would prefer to defer to you because I think
Yeah,
you
for
have
sure, for sure.
better
Yeah, and
information on that front.
yeah, and I think that with coping strategies, you can get creative. You can get as creative as you
Mhm.
absolutely want. But you first have to understand what is happening within you. And I think that what
Yeah.
we can sometimes do is get very disconnected from our bodies for various reasons. Sometimes it's protective. We're like, and I can tell you, like, I've been going through like a month of like grant after grant. And I've just been so stressed that
Yeah.
sometimes it's like I can't be connected to what's happening here in order to function. But I have to come back
Hmm.
to that, and so that I can also recognize what what my body is asking for. And so there's really
Hmm.
important pieces of information that you need to know to in order to be able to know if a coping strategy even works. So it's kind of like similar to how you have your biological, your social, your psychological. It kind of follows the same path in a certain way when it comes to your coping strategies. How's my body doing? What am I feeling? What am I thinking? You need all of these
Hmm.
things to be able to problem solve. They're all pieces of information. So sometimes
Yeah.
you're like, I don't want to look at what I feel. It's just your brain basically telling you something's wrong in the environment or something's good in the environment. Can you please check what that
Hmm.
is? So I can either reduce it or increase it. So that's it. You need to kind of start seeing emotions as a piece of information. If you don't have that, you don't know what to do. So that's another way where you're like your biology is connected to your like environmental
Hmm.
experience as well. So I think that you have to be able to check in with yourself. And when it comes to that nervous system reactivity, it might show up in a different way. I find for myself, like I start to get this buzzing in my chest, and I'm like, oh, signal. I need to start to do something to kind of like calm things down.
Hmm.
Or, you might notice it in your breathing or certain muscles, or you might feel like a numbness. Like you just have to start to kind of get to know yourself in terms of like what's actually happening and what that level of distress is. So when we are in a scale of 1 to 10, 10 being the worst, if we're at like a 9 or a 10, that front of our brain that's so important for being able to process information, it's offline. It's like, see you later. I'm in survival mode.
Hmm.
So that's why talking yourself through it doesn't work or will work very poorly. And you're going to get frustrated. Like, why isn't this working?
Hmm.
Uh, because your brain just has a hard time processing information at that time. So it's important when you're in those stages to kind of take more like body focused approaches, like whether it's like working with your senses or cold or like things that feel nice and fuzzy or like whatever that looks like to you. Like sometimes what I do is like I'll do like a plank and I'll hold the plank for like a minute and almost
Wow.
meditate through it. I tell you, get creative. I meditate through a plank.
Hmm.
And then when I sit up, it's like it just completely like calms down. So it's like again, like getting a sense of like where you're at and where your body is focused is kind of like a good place to start. Hopefully that answers your question. I can go on and on,
Well,
sorry,
thank you.
about all of that stuff.
Yeah,
So like
and
I'm
thank you.
gonna switch over.
Thank you for us too. I think this, and I think these your suggestions are actually universal. Like
Yeah.
I have some ideas now too. I tend to when I'm stressed, so like you were saying you have the buzzing, I get like warm feeling in my
Yeah.
abdomen sometimes, but I'll also notice like changes in breathing. And one
Yeah.
of the things that I like to do, not planks, it may be something I'll try in the future, but I usually bake. For me, not having my brain function as much and using my hands to do something is a nice way for me to get
Yep.
external from the body and just like focus on
Totally.
something else. And
Mhm.
focusing your attention on that seems to, at least for me, seems to help. And I love to bake, so it's a
Yeah.
good excuse.
Oh, that would be dangerous for me, but yeah, that makes yeah, no, for sure. You're basically just trying to get your brain out of that survival mode because once you're out of that, then the
Hmm.
talking strategies will really start to help a lot more. It'll be different.
Yeah,
So taking a stepped approach to your coping strategies is an important one. But other questions that we have here, let's get back to the questions,
sure.
is what do you envision offering a patient that's tested positive for one of these genes? Like, you get the news, juice, like what do you
Mhm.
assume at that point? Like, does it become like, oh, this is going to happen eventually? Or like, what does that mean? Um, or would at that point that person be put into another program to help with suicide prevention? Yeah.
I think that's a very good question. And actually, yeah, we don't want it to be like, okay, you have this gene, you have the altered expression. It's not a be all or end all. And coming back to what you were saying about putting someone into a program for suicide prevention would be one way. And this is something that we would also need to talk to our psychiatrist colleagues in our department with, and to also determine what could be done. It's more trying to determine which interventions maybe need to be put
Yeah.
into place, or if this would just require maybe spending more time with the patient when they come in for their appointment, just
Yeah.
providing more support in different forms
Yep.
is how we would see this going. Because
Yeah.
as we were saying, like just having the gene is not enough,
No, no, it's not. It's not.
right?
Like again, you don't inherit behaviors.
Yeah,
If you can take one thing away
yeah,
from this, it's like there's risk factors.
yes,
You don't inherit behaviors. Yeah, yeah. Um, okay, that's great. So there's another
sure.
question from the audience, um, from someone whose brother had died by suicide, and they had bipolar disorder, and
Mm-hmm.
this participant is female and thankfully says that she doesn't struggle with mental illness, but she says that, wondering about like how random that is. Like, is it like how one sibling can get certain features and others not? Is that a random thing? Is that something that is like, how do you explain that?
Okay. Well, thank you for your question. Actually, it's not that random. And the reason I'm actually saying this, so like we have evidence from twin studies and family studies. It's not always a one-to-one concordance if like a family member or sibling has a certain disorder that you would have it. We actually attended a talk just last week or the week before. It was the grand rounds for our department where they were looking at psychosis and schizophrenia in this instance, and in there, it was dealing with siblings, and you would have one sibling that was affected by the disorder. Meanwhile, the parents didn't have it, the other siblings didn't have it. So, and it was at that time that we realized it's not as random, or it's not as uncommon, that it doesn't actually run in families. So that's also an indication of the fact that we need to do a bit more research, and we need to figure out what else is impacting what is happening, because there must be something that maybe we have not found at a molecular level, or it's like you were saying, it's at a social or a clinical level as well that we haven't seen. But yeah, to the person in the audience, it's not that random, so it's okay.
Yeah.
Yeah.
Um, yeah, it's such an interesting thing how things track in
Mm-hmm.
families.
Yeah.
Um, so one other question around the
Sure.
potential for false positives or false negatives with biomarkers. Like, what are your thoughts on that? How do you think that things like that would be addressed? Could the test be wrong?
Mm-hmm. Well, okay. So that to overcome that, that's one of the reasons that we're uh, doing and revalidating the biomarker and other samples is to try and avoid that. So in our initial findings, we did do corrections for multiple testing, and that to make sure that what we found to be significant were at least not false positives. False negatives, hopefully not as well with our statistical methods, but the true test would be replication and seeing them again in different populations and different samples. So these samples are coming just from our hospital and our collection at UCI. So it would be interesting to see if another depressed collection from another academic institution would show the same results. And if that is the case, that gives us more confidence that we're not looking at something that is a false positive or a false negative and could be wrong in the end.
Right.
I
Because you
hope
can
that
have,
answered the question.
yeah, you can have suicidal ideation and may never attempt or die by suicide. In fact, that's the majority of
Exactly.
people, right? That
Mm-hmm.
still technically,
Yeah.
even though suicide is not an uncommon thing, it's still a relatively rare event from a scientific perspective.
Yes.
So,
Mm-hmm. Definitely.
yeah. So do you think that something like this would help resolve, like, you can have ideation, but you may not have these other risk factors?
Yeah, very much so. Very much so. It is in
Okay.
the end, I think, all about information and gathering as much information as you can. But yeah,
Yeah.
no, definitely. I hadn't thought of it in that direction, but for sure.
Yeah. Okay. Amazing. So maybe we'll have time for one last question. Actually, maybe also,
Sure.
I think we've answered all the questions that people have asked. I like to end off these kind of sessions with like, what is the hope for kind of going forward in terms of what this can actually help with? What's the hope for families and individuals? Where do
Hmm.
you see this in that context?
Uh, I well, I do hope that this eventually, like, my hope is that we can get this to be something that can be implemented in clinic sooner rather than later. Because if this can help in any way to help uh, start intervention programs or prevention programs early enough, if we can save one life, it's already doing like all our work is already like it means so much, even at that stage. But my hope is that we do have something real that can be
Yeah.
implemented in the clinic and that can be translated to patients as soon as possible to really help them and not have this be the end result in their journey.
Absolutely. Maybe actually, I was gonna have with that question, but then we got one last one, so maybe we'll ask one more. And I think it's a really important
Sure.
one. So, how are EDI principles addressed to ensure a representative sample? How generalizable do you think your findings would be across people with different experiences in life and people who are neurodivergent?
Hmm. That is a that is a good question.
That's a
Um,
good question.
that is a very, very good question. Um, I think at this stage, this ties back into the other question about applicability. And yeah, I think we will have to test in other populations and see because even being neurodivergent or other uh, ethnicities and races, we psychiatric disorders do have um, common alterations in biological systems. So it would be, I would say we would have to do more research. I wouldn't be able to confidently tell you how one to one would be because our findings are really in depression. And even if you are neurodivergent to have depression, your presentation or your biology might be different, and it's something we can't at this stage we could not tell. But it's definitely something that we would need to look into.
Yeah,
That would
and
be
I think
useful in the future.
totally, and I think that really speaks
Mhm.
to even in terms of like AI modeling, all of those things need to kind of
Yes.
incorporate information from diverse representative like
Mhm.
groups. These
For
models,
sure.
biology are not just based on one group of people, so that it can be represented.
Hmm.
That actually leads me to thank you everyone for joining because next month, Dr. Diana Clark, who is from Johns Hopkins and the president-elect at the International Association for Suicide Prevention, is going to be speaking about cultural aspects of suicide risk.
Oh, nice.
So please join for that and re-ask that question as well in terms of like what what are the things that we're doing to kind of integrate culture into what we're doing as well. So thank you so much, Firoza. It was really, really a pleasure to
Thank
hear your
you.
talk, the work you're doing, and to share with everyone. So thank you very much taking all this time out of your conference to come sit with us and chat. And we'll see everyone next month in December.
Next month, I'll be there too.
Okay,
Yeah,
great.
thank you
Awesome.
guys. Thank you.
Thanks. Bye.
Bye-bye. Bye.